So, welcome to this episode of Menopause Conversations. My name is Amantha King. I'm a workplace menopause consultant and I'm an executive coach. And I'm delighted to have my returning guest and friend, Dr. Shilpa McQuillan. For those of you that are very big fans of this podcast and regular watchers, you'll recognise Dr. Shilpa. She's a brilliant community gynaecologist and GP. It's really a case of what can't she do? That's what I always think when I think of Shilpa. What can't she do? But Shilpa had an idea, and she thought it would be good for us to talk about it. And I was like, yes, we absolutely do need to talk about this. So this episode is called Burning Questions. UTIs and menopause. Did you see what we did there? Because actually, if you've ever had a urinary tract infection, it is without doubt one of the, look at Shilpa's eyebrows, it's one of the most painful things on the planet. It's almost indescribable, isn't it, Shilpa? So welcome, Shilpa. Lovely to have you on the show again.
Thank you for having me back.
Yeah, so you are so welcome because the lovely thing about Shilpa, well, just one of the lovely things is that she makes things so easy to understand, really accessible. So, first of all, Shilpa, we're going to keep this nice and punchy and short, but let's talk about what does UTI stand for? What is a urinary tract infection?
So you've kind of
I've stolen your
pronounced it.
thunder,
So
sorry.
no, it's all right. So urinary tract infection. I'm going to actually get my model, Amantha, because I find this is really, really useful to have. So this is my vulval model. So this is my the vagina, and then in here is the urethra, which is the entrance to where the tube would go to where your bladder is. So urinary tract is anywhere from the start. So your urethra here into your bladder, and then beyond that are two tubes that come off the bladder that go into your kidneys, and that is our urinary tract.
Okay, amazing. So, anatomically, that's in a different place, for example, for the female clitoris, isn't it? So, would you mind just showing on your model, just in terms of the proximity for
Absolutely.
people?
Yeah. So this is really important because actually it can often be mistaken quite obviously. So your clitoris is up here. In fact, I'll just give a quick demo, shall I, of the
Yeah,
anatomy.
go
So
for it.
your clitoris is up here, your external vulva, your internal vulva, your vagina is here, your urethra is there.
Yeah, because the thing I can definitely share is it doesn't feel like it's there though, does it? You know, if you get the pain of a urinary tract, it can almost feel like it's coming from up higher, and so that can be what's quite confusing for people. It's like, what is that pain? What is that? If you've ever had a urinary tract infection, you know when another one is starting. You start to get quite sensitive to it. So I suppose the thing that we want to ask is, why do we get these urinary tract infections around the time of menopause? What's going on? Can you help us understand?
Yeah, absolutely. So I guess there's two ways of breaking down. As women, generally, we are naturally more prone to having urinary tract infections. And the reason being is this point I've showed you, the start of our urethra, the tube is very short to get to our bladder. So that means the bacteria doesn't have far to get to the bladder compared to men who have a much longer tube. So generally, as women, we are prone to them anyway, unfortunately. What happens around perimenopause and menopause, and it may actually surprise a lot of women, is that it's not due to all the reasons we're told when we're younger as to why we get urine infections. So, for example, bacteria transferring for during sex, wearing underwear that's really tight, just generally, like I've said, you've been prone to urine infections. It's actually due to lack of estrogen. So, what happens is our vagina is in very close proximity to our urethra. So when we have any extra bacteria, any loss of estrogen, which means we lose collagen, lose glycogen, the skin breaks down. We don't have that barrier anymore. So we're more prone to infections in the vagina. So most people won't realize that actually most urine infections around menopause happen because of that lack of estrogen, because of all the issues that happen around the vulva and vagina. The bacterial infections ascend into the urethra and then into the bladder. That's one reason.
Okay.
Another reason is people don't realize is we've actually got estrogen receptors, can you believe, in our urethra and in the body of our bladder. And not many people know that. So when we're losing estrogen, we always talk, don't we, about the vulva vagina, but actually it can really affect the urinary tract as well. So, like in the vulva and vagina, we need to have a nice biosis. Our bacteria needs to be good bacteria. Similarly, that can happen in the bladder, where there can be changes to the good bacteria and then more bad bacteria come. But the other thing is the structure changes. So women will find, won't they? They start talking about prolapse. I'm getting that dragging sensation. I'm constantly needing the toilet. I can't wait to get to the toilet. That can all be contributed by lack of estrogen. When that happens, the tissue becomes more lax, and things like your bladder can't empty as properly as well, which means that your urine stays there for longer, and then you end up with more bacteria, have longer time to sit in there rather than being flushed out. So as you
Yeah,
can see, there's like multiple processes to why that can happen.
yeah, and I think it's so fascinating. Thank you for explaining that so brilliantly because before we recorded this, I was reading some statistics to Shilpa. So for the audience, I'll share them also. By the way, we caveat all of this with Shilpa and I think this is massively underreported, but your lifetime risk of having a urinary tract infection is about 50% for women in the UK, which will experience at least one urinary tract infection in their lifetime. That itself, that's too high. We should be doing something about that. We know that it says the estimates suggest that 3 to 50% of women may experience recurrent urinary tract infections. So I'll come to that in just a moment. But this does sort of lead into, maybe women don't realize that maybe the starting point for lots of this is, lots of those trips to the toilet at night as well. That urine, that nocturia, getting up, going to the toilet at night, maybe the frequency of going to the toilet. These are all signaling. We know that progesterone as well has some really lovely benefits for nerve function too, don't we? And that actually nerves are more protected. So I think these could be some sort of little watch outs for people, which is that changing for me? Am I literally like that latch key moment, like I've got to get to the toilet, only to get there and only a dribble comes out? It's that sort of thing. We hear women talk about that all the time, but talk to us about the very serious aspect of urinary tract infections because there is a strong correlation with mortality, isn't there, Shilpa?
Yeah, absolutely. So one of the reasons I'm so passionate about this, I do a lot of presenting nationally about urine infections, is because when we think about the elderly population, urine infections are one of the biggest mortalities. So it's the biggest killer, in particular in things like care homes. Now, if we think about what I've just been saying, that if you are perimenopausal, menopausal, postmenopausal, and you're getting more recurrent urine infections, and it could actually be due to estrogen, then these people are not necessarily getting the correct treatment that's going to keep these urine infections at bay. Sometimes you might get, for example, antibiotics and you do feel better. But I'm sure there'll be listeners here thinking it does, but it's a temporary fix and then it happens again. And so it's important we're getting to the crux of it. Actually, is it that we need antibiotics? And don't get me wrong, there often is that need to get rid of that acute infection when bacteria are already hung on and we need to get rid of them and kill them. But actually, how could we prevent it in the first place? Not fighting fire. How can we actually stop this and think about it a lot earlier on? And could we be doing things like treating it with estrogen, topical estrogen? And even with HRT as well, systemic estrogen can also be absolutely effective. And I often say in women who are taking systemic estrogen, when they're getting specific urinary or vulval vaginal symptoms, let's add that in. Let's get on top of this really well rather than just treating it a little bit, a little bit.
Yeah.
The other reason it's important, Amantha, not only is it the highest mortality, but what does recurrent antibiotics do to people? And in the elderly in particular, not only are we having resistance to drugs very much more now than ever, but our gut is so disruptive. And in particularly in elderly, it can cause colitis, and colitis can kill patients as well. So that's inflammation, generalized inflammation of your bowel that can occur because your gut is just totally disrupted from antibiotic use
Yeah,
recurrently.
it's really a vicious cycle, isn't it? You made me think there about that strong correlation between, people's understanding. I think sometimes we take our understanding from other aspects, like, yeah, if I'm going to have antibiotics, I'll have that for 2 weeks. That isn't really what we're doing with localized estrogen, is it? It's not like, oh, it all feels better. Bin all of that. I don't need it anymore. So could you just help explain really what is going on there, and why we once we start, we really need to continue. Can you explain why?
Yeah, absolutely. And the way I explain in clinic is when you think about things like paracetamol when we've got a headache, it's a quick fix, isn't it? It can really help take away the pain. That's all we need. We might never need it again. The difference with what we're doing with estrogen is we're replenishing what we're losing. And we want to keep that going. So we're not only just treating our current symptoms, we want to prevent it getting worse. I always talk to my patients about make you live your best life rather than coming to me when it's so detrimental and you're fighting fire and things have just gotten awful. Because at that stage is then everything gets worse. Your chronic UTIs are quite impossible to get rid of. You get everything fuses together, it becomes more painful, dry. So what we're doing is it's not a quick fix. What we're trying to do is replenish, estrogen is replenishing that tissue. So we're help maintaining that glycogen. We're helping long term maintaining the pH, the vaginal pH, to be more acidic, which means we have more good bacteria there, which means the skin is lovely and plump. So it's got a good barrier to prevent it tearing and more easily accessible for infection. If we only use it temporarily, it might feel okay, but then we're back to square one. We need to be continually using that to get that effect. And I always say to women, don't let anyone rip this tube away from you. You use that long term and you hang on to that for your life as well.
And do you have any example? Have you got any there, Shilpa? I've got some here. If just to show people what example of what we're talking about is localized estrogen. Can you explain to people what forms it comes in that people can access? Because some people will never have been offered this. Just to say, it is available on the National Health Service. If you're in Wales and Scotland, it's completely free. In the UK, it's the cost of one prescription for the whole year. But do you have any examples there with you?
I don't have samples because I'm not in my clinic, but I do have them. So maybe we should, I mean, we could do a whole podcast, let's be honest, and just showing estrogens, but
Yeah,
absolutely I can talk through them.
yeah.
So we have creams. So we have different types of creams, which come in tubes. You can have a applicator as well. So that what I always show people is where to rub it. So making sure that you're applying it in your around your urethra, your vulva, and then an applicator. Most of the creams come with it so you can squeeze the cream in. That's one form. You also can have different pessaries, and there's different brands. Some are reusable, so reusable applicators that come with the little waxy pessaries, and they go into the vagina. Some people just use their finger to
Yeah.
insert it as far as they can, so you can do that. There's other forms as well. And another example, really good one, is something called E-string. And that is actually a pessary. So it looks like a ring pessary if anyone's ever had one of those. And what that beautifully does is it sits in there and you can keep it in there for 3 months. And I particularly love those for my either elderly patients or people who find difficulty using their hands, or people sometimes don't like, do they, the thought of just doing that all the time. And so it's a lovely estrogen pessary that just sits inside like a ring and it releases estrogen slowly. So there's lots and lots of different types that we can have.
Yeah, I love that. Is it? I mean, I always imagine because the E string just looks like clear silicone, doesn't it? Um,
Yeah.
I always think, oh, am I going to feel that? Because obviously, if you show your model, if you show the back of your model, Shilpa, we'll see. Yeah. So the E string, does it sit somewhere in that bit, or does it literally just sit in the opening?
No. So can you see? So this model, I'll be honest, this is probably a better bit. There's my other model. I often
Okay.
just put these two together when I'm demonstrating, for example, how to do a smear. So what you would do is what happens, it's a shame I haven't got the one that's got the bladder and bowel. But if we look at this, this is our womb. Okay, I'm going to show it from the sideways.
Yeah.
If we look at the womb, you've got your bladder that sits here,
Yeah.
okay, and you've got your bowel that sits here. When you have something like an E string, so this is your vagina, that's your
Yes.
cervix, the opening to your womb. What you will do is the doctor or whoever shows you how to use it will literally just squeeze the ring together, push it in, and then it just nicely sits somewhere in the vagina here.
Yeah. So
And
it's almost just compresses, doesn't it, to take the shape?
yeah, and it'll expand. If you're having one, a lot of women have for prolapse, where they're having it, let's say your bladder is bulge, your wall is bulging here, it nicely just sits and it shelves it up. And so often I'll use the two together actually,
Oh,
because the two often
really?
go hand in hand. Because as I said to you, the lack of estrogen causes our bladder to relax and then it doesn't allow urine to release so easily. But also prolapse symptoms are similarly due to lack of estrogen. So sometimes it's quite nice to use both, like actually physically helping the prolapse and then giving that estrogen as well.
So the natural question, just because I like no filters here, what happens when you're having sex, Shilpa? So if you are having penetrative sex or using sex
Yeah,
toys, um,
yeah,
like vibrators and
absolutely
things,
fine. It's the beauty of it being a ring. So a lot of pessaries used for prolapse can have like what we call a shelf pessary. It comes with a big tube hanging down. You can't have that for sex. But the ring, because it's taken a ring shape around here, you're still able to have penetrative sex. Sorry, can you see my
yeah,
finger?
yeah. So it's
Yeah,
really light. You know, when you look, like I went to the gym this morning and I had my little overnight oats, and you know, you've got that silicone ring that's sort of on your jam jar lid. It literally is like that, isn't it? But it's got form to it. So it sits like that
yeah.
in there rather than lying flat. So it's not like things are going to bump up against it. It's actually
No, it
all
does
in
it
the
at an
right
angle.
place.
Our anatomy is at an angle, as you can see. It
Yeah.
does, our anatomy isn't just straight like that. So it will sit at an angle and so people can have
Even
intercourse.
if you're, I mean,
Absolutely.
obviously I'm asking for a friend, but even if you're, so obviously when I go for a smear, my cervix points backwards. So it's always a nightmare having a speculum put in. Any issues for people? Because again, I know people will ask me this. They'll go, "You didn't ask that question." Anyone with a cervix can have that, whatever, if it's retrograde, whatever you're positioning, it's absolutely fine.
Absolutely. And one thing to note though is because people's anatomy is so different, like anything, some people, like even like when you're straining or even just walking around, sometimes it can fall out. But that's because of the way our anatomy is. So that is a risk with anything that you have in a foreign body. But in terms of can anyone use it? Absolutely. Yeah.
Lovely. That's what that's pretty much what I thought. So is there anything else we haven't covered, Shilpa, that would be really helpful for people to know? Just in summary, the things that I've heard there is, urinary tract infections are different as we get older. It's not the same as it was when we were younger. There are other causal links to that. Mostly it's about the integrity of the skin, it's about the pH changing under the influence of declining sex hormones, notably estrogen, but obviously progesterone, testosterone, and the skin integrity changes, like our collagen to elastin ratio changes. It's more prone to breaks and things. It's like today, look, I went to the gym and I got a massive blood blister. It's like, well, where's that come from? Things are changing as we get older. I suppose the one thing we haven't maybe talked about is, you know, when we get older and, how important our own hygiene is, because of course the anus is in quite close proximity. If we spend a lot of our time sitting down, that's another path of pathogenic sort of entrance, isn't it? And we know that there are some products there that can help with that, but generally I suppose the thing is, how soon should people be considering localized estrogen? Is it the minute you've had a urinary tract infection, or could we be taking more of a preventative approach? Because I'm sure there'll be lots of people on here who've gone, "I didn't even know that existed." So, what would you say would be your course of action that you recommend?
See what you saying to me about is there anything else we haven't covered is exactly what I was going to say is making sure we still take a very individualized and holistic approach to this. And what I mean by that, it's still important to find out in your lifestyle, could there be things that could be contributing to urine infections or even worsening loss of estrogen? So, for example, things like smoking. Could things like the amount of alcohol or caffeine we drink contribute to our symptoms because they are diuretics, so they make us pee more? They are also stimulants so that they can make our bladder and that area feel more aggravated. What we eat is integral, and I could do a whole webinar about this. There's a lot about gut microbiome and biota, isn't there? But what about our vaginal microbiota?
Mm.
I've just talked about how that's really important. What we eat, what we put in our body is also hugely important. And I always say keep a diary because many people will find there are triggers in that sense. Then, of course, so eating, drinking. Then, like you say, not necessarily hygiene, but absolutely do keep in mind, like wiping front to back, because if we wipe from our bottom is where our E. coli live, and that's the majority, not all, majority of what urine infections are, the bacteria. So making sure we're wiping away from that. I talked about that it's less so about clothing, but actually it's about people as an individual and quality of life. And some people will say, I know I do, if I wear very tight underwear, by the end of the day, I do feel like, oh, I need the loo. Is that a urine infection or is that irritation aggravating it? So everyone's individual of what will affect them. So keep a diary. Lifestyle is huge. And one thing I've missed is mental health. when we think about our mental health and our gut, how much do the two interplay? The same is very much the same with our bladder and our vagina and vulva as well, is that a lot of people will find that their urine infections are triggered with mental health or when they're more stressed as well. So it's really important we look at everything as a whole. And then when we're thinking about estrogen, absolutely we should be doing it as soon as possible. But it's about taking a really good history and say, not just jumping at everyone with
No,
one treatment,
no.
looking at all of it. And there's lots of things you can use. Some people find over-the-counter medications useful. Some people find that there's some other medicines like Hiprex on the system, which is an it's not an antibiotic, but it prevents the bacteria. It stops it from sticking there. And then there's things like, can you believe there's vaccines now as well that can help with prevention? And then there's other things like, and there's a bit, the studies are very variable in this, but things like cranberry and things like D-mannose, they're sugar substrates that basically stick to bacteria and try and flush them out your bladder. So there'll be people listening here going, you haven't covered those, but they are absolutely integral. But some people that might not work. And I've got to say, with urine infections, it is very much individualized because what works one doesn't necessarily work for the other. But hopefully, what we've given people is an idea that actually, if you haven't thought about estrogen and you're just being given antibiotic after antibiotic, what effect not only could that do to you, but actually it might not be getting to the source of what's going on as well.
Yeah, exactly. And you prompted me to think of two more things there. So one of the things that, I think we get very comfortable going for, any type of infection, urinary tract infection, candida infection. We sort of go, oh, just treat it with that over the counter stuff. But actually you have to draw a line somewhere to go, do you know what? This is the X number of infection I've had. I think usually that's the time to go and seek some professional help, someone who can really sort of scope out what's been going on for you. The other thing that I was just going to ask you, which drives me absolutely insane, is the commercialism of menopause. I see perfumed washes, I see intimate wipes. Do we really need all of that? Because isn't really the vagina a self-cleaning vessel? Do we need to be putting perfumed soaps and gels and flavors anywhere near that? And thinking about intimacy as well, these lubes that have a high sugar content, I know what you're going to say, but for the purposes of our audience, maybe you could give
Yeah,
an opinion on that. I mean,
yeah,
the shelves are heaving
yeah.
with stuff, Shilpa. What should we be doing or not be doing, really?
Of your questions. Firstly, I want to say you've brought up a really good thing about going to see a doctor. But where I've demonstrated the anatomy, can the people watching our podcast also see how easy it is to go, I'm stinging down below, or it burns when I pee, when actually, how important is it to be examined? Because you wouldn't believe, especially now with telephone consultations, burning when you pee, and it could be on the vulva, could actually be a vulval cancer. Because,
Yes.
you know, it's so important that you know your anatomy, and it's so important you're not just getting over the counter treatments like thrush or just your antibiotics, because absolutely, like you say, for safety reasons, we need to know our anatomy, we need to be examined, and we need to be investigated if things go on and on. That's one thing. You're going to probably have to stop the webinar because I could go on now about these lubes and these washes and the monetizing of menopause and all kinds of women's health products. The vagina is completely self-washing. And not only am I going to say, you asked me, do we need it? I'm going to say the complete opposite, and please don't use it. Because a couple of things. When you wash your vagina in here, you are washing away the good bacteria, which means your bad bacteria are setting in. So, firstly, we're already disrupting the pH and washing away all those lovely lactobacilli that want to live there and look after us, firstly. Secondly, absolutely, all of these things, and you and I both know there's some very good medical products that are lubricants and things that are good approved products that I scream about, and I don't have any endorsement with any of them, but we need to look at them because they look after the pH of our vagina and vulva, but also they don't contain parabens and all these sugars that thrush love, that urine infections they absolutely love. This is what they live off. They love sugar. They eat that sugar.
Yeah.
So absolutely we need to be careful. By all means, you absolutely use lubricant, use things, toys, sex toys, and play lubricants, but look at your ingredients. It shouldn't contain anything artificial that's got sugar, parabens, anything that could disrupt the pH or look after our vulva, vagina, and our urinary tract.
I 100% agree. And can I add on to your very brilliant point that Diane Dancebrink produced this book, Menopause Understanding Menopause, and I absolutely love it. And do you know what someone said? And I thought this was just a game changer. You know, when you hear people go, do this, and I was like, how did we not think of that? She actually has put in a picture of the vulva in the leaflet. How good is it to maybe draw on where you feel the discomfort so that you can actually say to the doctor, or even take a picture of your phone, send it in for your phone consult, rather than, and this still happens, doesn't it, Shilpa? People going, where are you uncomfortable? And you say, it's down there. And they go, okay, how does it feel downstairs? Let's start using the right terminology. And the way that we can
Absolutely.
do that is to maybe have something like this and going, look, well, that's, I don't know, but that's where it feels. So get a pen and mark an X on it and go, that's where it feels sore to me. And you're absolutely right, because we know that things like lichen sclerosis, lichen planus, we know that these things are part of the genitourinary syndrome of menopause and vaginal atrophy. When everything's thinning, it becomes a lovely breeding ground for other things. And you know, lichen sclerosis, there isn't a cure for it. We can only really manage the symptoms. And you know, we had Claire Baumhauer on here talking about her cancer, and it is one of the saddest stories of missed opportunities. So you're absolutely right, and that's why I feel really passionately. Let's get to a point of right, okay. I mean, I know patient info leaflets aren't always helpful, but if you've had one or two rounds of something and it's not resolving, you're not
Yeah.
inconveniencing anyone. Go make a case for yourself. And I'll tell you where I found to be really useful. When I couldn't go and see my GP, I used to go to my local sexual health clinic and never was turned away. I could self-refer there, and they were absolutely lovely with me when I had lots and lots of infections during my perimenopause, and I felt really well looked after, Shilpa. I think I probably saw amazing people like you, but in a community setting. So yeah, I think you know what, you don't need to go down a menopause aisle. You definitely don't want stuff with sugar, because we have sugar dysregulation during perimenopause anyway, and insulin resistance. So our body's sugar is not really our friend during that time. But I suppose the great thing is, if people have questions, they can be in touch with you. Your website is amazing. And what I didn't say about Shilpa, which I just want to say right at the end, is Shilpa is often asked to give commentary. She's on radio stations. She's seen as an expert. She's seen as somebody that people can rely on. I certainly rely on her massively, and I couldn't think of anyone better to have this conversation with. So I'm going to leave the summary to you, Shilpa. In summary, when we think about the burning question of UTIs and menopause, what are the take-home messages for people that you want them to take home today?
Yeah. So my take home is know your anatomy firstly, so you can get the right diagnosis and the safe diagnosis. Make sure we take a holistic approach. So keep symptom diaries so you know what your symptoms are and you know what's different for you. Let's look at it in a very holistic way. So absolutely, antibiotics can be integral. I am not an antibiotic. I'm a GP. I absolutely believe in them, but it could be something else. And in particular around perimenopause, could it be lack of estrogen? So therefore, what else could we do? Could we look at our lifestyle? Could we look at diet? Could we look at our mental health and stress? Could we look at products that we're using like we described? Could we look at absolutely vaginal estrogen? I saved the best till last. Sorry, vulval, vaginal, and urethral estrogen, genital urinary estrogen, I call it. I don't call it vaginal estrogen for that very reason I've told you. So it is encompassing all of that. So are there things that we can be doing as a whole to help you as a clinician? But what things can you also do with that symptom diary and just looking at things that trigger it for you and making sure you get the right help and asking for estrogen, because after menopause, that is more likely to be the reason for your urine infections than just having antibiotic needing driven bacteria.
Yeah, absolutely. So how can people know more? Because Shilpa is brilliant. She does loads of short videos and things like this. And like I say, she's a real fountain of knowledge. How can people consume more of your stuff, Shilpa, on your channel? I mean, because you've got loads of stuff on my YouTube channel, but how can people see stuff on your channel? How can they find more out about you?
So yeah, thank you for the lovely comments about my website. So I've got a website, so it's www.berkshiremenopauseClinic.com, and I've got lots of free resources. I write for a newspaper and a magazine, evidence-based information, by the way, as their women's health columnist. So I have a monthly column that you'll find that free on my website. I've got leaflets I write for patients. I've got a YouTube channel, again, Berkshire Menopause Clinic. and I do a monthly blog if you sign up with lots of tips. And you can find me on Instagram as well, Berkshire Menopause Clinic, and Facebook and LinkedIn. If you want to, if your company needs a talk, I am very, very happy to, I'm very enthusiastic about it. I will bring my models if you want me to as well, but I'm Dr. Shilpa McQuillan on LinkedIn as well.
Yeah, lovely. So Shilpa, all that's left to say is thank you so much. We are going to do some more of these talks as the year goes on. Please put stuff in the comments. If you've got any questions at all, Shilpa and I will review them either on the YouTube, put the comments, or on LinkedIn or on Instagram. We can't give specific medical advice to people, but actually, we want you to ask the questions, and if we can come back to you, we absolutely will. And if you've got any other topics you think you'd like us to talk about, we're
Yes.
really happy to do that too. But for now, my lovely friend, Dr. Shilpa McQuillan, thank you so much for giving your time, and I shall see you sometime soon.